Hello and welcome. My name is Matthew, and today we're going to be looking at a paper titled How to Survive the Medical Misinformation Mess. This is a paper that was published in 2017, so it was published before all of the madness of the last couple of years, but it gives a very good insight into some of the reasons why things went so wrong. The authors here are listed, which you can check out, but let's just get straight into the abstract. So, most physicians and other healthcare professionals are unaware of the pervasiveness of poor quality clinical evidence that contributes considerably to overuse, underuse, avoidable adverse events, missed opportunities for right care, and wasted healthcare resources. The medical misinformation mess comprises four key problems. First, most published medical research is not reliable or is of uncertain reliability, offers no benefits to patients, or is not useful to decision makers. Second, most healthcare professionals are not aware of this problem, which is a huge issue. Third, they also lack the skills necessary to evaluate the reliability and usefulness of medical evidence. So again, that's quite a shocking thing probably for most people to hear, that a lot of the doctors and other healthcare professionals lack the skills necessary to evaluate medical evidence. Finally, patients and families frequently lack relevant, accurate medical evidence and skilled guidance at the time of medical decision making. Increasing the reliability of available published evidence may not be an imminently achievable goal. Therefore, efforts should focus on making healthcare professionals more sensitive to the limitations of the evidence, training them to do critical appraisal, and enhancing their communication skills so that they can effectively summarize and discuss medical evidence with patients to improve decision making. So let's read into the paper a little bit more. But again, even just to start off, those are quite shocking things to hear. Currently, there are approximately 17 million articles in PubMed. So that's a medical database where you can find a lot of the scientific literature, with over 700,000 articles identified as clinical trials and over 1.8 million reviews, approximating 160,000 systematic reviews. So naturally, when there are so many hundreds of thousands or millions of articles relating to medical information, no single individual can really go through that. And so quite often they're actually relying on other people to tell them what the information is. And that's a huge part of the problem. Moreover, this paper will get into a little bit of the information about what goes wrong whenever doctors listen to things like guidelines and about how spurious some of the evidence is that those guidelines are based upon. So let's read further. Unfortunately, much of this information is unreliable or of uncertain reliability, and most clinical trial results may be misleading or not useful to patients. Most guidelines, as I mentioned, which many clinicians rely on to guide their treatment decisions. So there's also this other pressure that if they don't follow the guidelines, which may be wrong, that then they could lose their license and could be held liable for that. And so most guidelines do not fully acknowledge the poor quality of the data on which they are based. And again, there's a reference there for people who want to dive a little bit deeper into looking up those. Also, most medical stories in the mass media do not meet criteria for accuracy. I think that's pretty obvious. And many stories exaggerate benefit and minimize harms, which we have seen in just ample evidence. So a great example of that is the 95% effectiveness of the vaccines in stopping people from getting COVID and things. And as we seen in our last video, as we went through the evidence of the randomized controlled trial that led to the approval of the mRNA vaccines, specifically Pfizer's, the 95% effectiveness in absolute terms, which is a more accurate number for people to understand in regards to their individual risk reduction, was less than 1%. But again, that's information that very, very few people ever came across over the last few years. Furthermore, clinicians and patients often do not recognize how pervasive this problem is and how profoundly it affects the care they deliver or receive. 20 to 50% of all healthcare services delivered in the United States is inappropriate, wasting resources, and this is the bit that's hard to read, harming patients. So it's not a simple thing that, there's some bad information that's out there or, some of the guidelines may be a little bit skewy. It's that people actually get hurt when these decisions are made that follow poor evidence. Much of this waste is due to overuse of medical interventions, resulting in an unknown amount of preventable harms. Very sad. And underuse of effective and safe interventions further compounds the system's failure to meet patients' needs. While there are many causes for inappropriate care and waste, much of it may be attributed to the poor quality of information that clinicians and patients rely on to make decisions about the services they deliver or receive. We use the term medical misinformation mess to encompass the set of issues that relate to the low quality of medical information deeply embedded in clinical processes and decisions. Although this mess affects multiple stakeholders, our focus is mainly on the clinician and patient issues and on remedies for those aspects. So again, just once more, what are those 4 key issues of the medical misinformation mess that we're seeing? Number 1, much published research is not reliable and it offers no benefits to patients and is not useful to people trying to make medical decisions. Most healthcare professionals are not aware of this problem. Number 3, even if they are aware of the problem, most healthcare professionals lack the skills necessary to evaluate the reliability and usefulness of medical evidence. Again, quite a shocking thing, as a lot of people think that other medical professionals go to university, they spend many years training, that there's a huge amount of resources poured into these things, and for them to find out that they actually lack the skills necessary to evaluate scientific evidence, it's quite gutting, really, to come across that. So finally, number 4 again, patients and families frequently lack relevant, accurate medical evidence and skilled guidance at the time of medical decision making. So to get further into problem 1 about how most public medical research is not reliable and offers no benefits to patients, this paper continues that most systematic reviews and meta-analyses appear to either be not useful or of uncertain utility, and the majority are unnecessary, i.e. duplicative, inaccurate or misleading due to the biases in the methodology and selective reporting of results. So, usefulness of clinical research requires existence of a real problem to address, proper context placement, sufficient information gain, patient-centeredness, pragmatism, reasonableness for value of money, non-futility, and transparency. Very few clinical studies meet at least 6 of the 8 criteria. In one survey of 60,000 studies, a meager 7% passed the criteria of high-quality methods and clinical relevancy, and fewer than 5% passed the validity screening for an evidence-based journal. Uncertain or poor quality evidence leaves clinicians, often under pressure, without definitive information regarding possible treatments. For brevity, our focus here is on the therapeutic interventions, but similar problems are found in publications dealing with diagnosis, prevention, and other areas of medical care. The large amount of accumulated misleading information is difficult to extract from the literature. So as you mentioned, if there's over 1 million different scientific publications, to try to find the gold amongst the dirt there is a difficult task for anyone. And so nobody really has the time, no single individual who ever gets home from work after dealing with a difficult day of dealing with a multitude of patients, a lot of people who are in pain or are struggling, and it's a very emotionally taxing job as well as physically and mentally exhausting. Get home from work, the last thing that they want to do is sit and sift through different scientific papers. And as we mentioned, most of them are false and are nonsense and are misleading. And so that's one of the big issues. Let's continue. Problem number 2. Most healthcare professionals are not aware of this problem. So based on training thousands of attendees at their educational programs and professional interactions with colleagues at all levels, from young trainees to top clinical and academic leadership, we are convinced that very few healthcare professionals are aware of the pervasiveness of biased and inaccurate medical literature. It is our combined experience that ignorance of this problem, even at the highest levels of academic and clinical leadership, is profound. So that's something for the public to bear in mind as well whenever they're interacting now with our medical system. Evidence for this ignorance emerges also in several studies and surveys. In a study of journal reading habits, internists reported they obtained information mostly from abstracts and not the full articles. So most people don't bother to read the scientific papers, they just read the abstract of it. And as we'll read here, they actually rely on editors of the journals to assure the rigor and study quality. Such trust is misplaced. For example, a recent study showed that several editors of peer-reviewed journals could not tell whether a trial was randomized without a special checklist. Even then, of the 324 studies editorial staff considered as randomized trials, only 39% were actually not randomized. So as we see, Most people that get home from work, most different medical professionals, they don't bother reading the medical literature. And if they do bother, they're probably only going to be reading the abstracts. And even then, quite often the abstracts are misleading. The medical journals that they're being published in via this peer review process, the peer reviewers are getting it wrong. So that really is a huge issue that, we're not going to overcome in the short term, I don't think. Further, many healthcare professionals put too much trust in abstracts for filtering the literature, or expect that systematic reviews or guidelines, and again, systematic reviews being pretty much our highest level of scientific evidence, and they think putting faith into them or the guidelines will get rid of the unreliability and the non-utility trouble. Clearly, the reliability of a study's results cannot be accomplished solely by reading the abstract. One study found that nearly half of abstracts of randomized control trials, again, nearly half of them contained biased reporting of study results, implying benefit when there was no statistically significant difference in the primary endpoints between the study arms. Flawed primary studies are compounded by flawed systematic reviews and lead to flawed clinical guidelines that make for conflicting recommendations unsupported by reliable evidence. Most healthcare professionals are not even minimally aware of these issues. I think that's probably the most important paragraph in this paper, and really we need to spread this message so more and more people are aware of it. Just to read that once more. The initial studies are flawed, and then those initial studies are pulled together into systematic reviews, which again are flawed, and then they lead to flawed clinical guidelines. And most healthcare professionals are not even minimally, they use the word minimally, aware of these issues. Problem number 3, most healthcare professionals lack skills in being able to evaluate the reliability and usefulness of evidence. In our encounters with students, clinicians, and others working in the industry, we have found a lack of basic skills required for determining a study's reliability and applicability. For example, in a pre-test administered to a sampling of more than 500 physicians, more than 500 doctors, clinical pharmacists, and other healthcare professionals attending evidence-based medicine training programs, 70% failed a simple 3-question critical appraisal training program test. The 3 pre-test questions were designed to determine if attendees could recognize the absence of a control group. That's crazy. Understand the issue of overestimating benefit when provided with a relative risk reduction. And again, this is something that came up in our previous video looking at the mRNA vaccine trials. So again, understand the issue of overestimating benefit when provided with relative risk reduction information without absolute difference information, and determine whether an intention to treat analysis was performed. Surprisingly, among those who reported feeling confident to evaluate the medical literature, 72% failed the test, even with generous criteria for correct answers. We have repeated the same pre-test with various groups each year with similar results. To continue, critical appraisal skills matter greatly for assuring optimal patient care. When practicing clinicians cannot distinguish between valid and false results, they are at risk of delivering useless treatments or worse, and this is the bit that's heartbreaking, harming their patients. For example, evidence of a 4-fold increased risk of myocardial infarction, i.e. heart attacks, in patients receiving a drug that was commonly known as Vioxx, which I think a lot of people heard of. This is a drug that led to the deaths of tens of thousands of people. Actually, the company that was responsible for this was Merck, and they actually had a criminal fine of, I think it was, almost $1 billion for the kind of harm that they caused here. And while we're speaking about criminal fines that these large pharmaceutical companies had, the largest criminal fine in history, interestingly, was from Pfizer, who had to pay $2.3 billion. And again, the reasons why they had to pay that, let me just scroll up here. So this is an article from The Guardian. Again, I'm not even going to show The Guardian's details because they're actually not a very reliable paper these days, and I would recommend people to avoid them. But this was an article back in 2009, where they may have had a bit of integrity left. It says, Pfizer, the world's largest drug company, has been hit with the biggest criminal fine in US history as part of a $2.3 billion settlement with the federal prosecutors for mispromoting medicines and for paying kickbacks to compliant doctors. All right, I'm just going to get back to the paper. I'm not going to comment on that much more. So as we were saying, there was a fourfold increase of myocardial infarction in patients receiving this drug, Vioxx. As we said, it killed tens of thousands of people, which was plainly available for people to know, which was written even in the abstract of the Vigor trial. It's probably the trial that got it approved. However, peer reviewers, editors, and readers of the New England Journal of Medicine, which was widely regarded as probably the best or one of the best medical journals in the world, accepted the spurious argument that this drug was cardioprotective. And not only was it harming people in terms of the cardiovascular system and causing things like heart attacks, they accepted that it was cardioprotective. That's how bad that this problem is. The Vigor investigators concluded that the increased risk of myocardial infarction with this drug did not exist, stating without any supporting evidence that the results are consistent with the theory that this drug has a coronary protective effect. Millions of prescriptions were written before the drug was withdrawn on the market in 2004, after several studies reported significantly increased risk of cardiovascular events and deaths. And so that's the big issue. A lot of these drugs get approved and then, huge amounts of money are paid out to compliant doctors and to regulators and so forth. And then it's only after a huge number of people are harmed that the investigations take place and then it is removed. But it's after the damage is done and after the profit is made. The potential risk of delivering poor care might be mitigated if healthcare professionals follow trustworthy clinical guidelines or base their actions on reliable systematic reviews and meta-analyses, which ought to weed out false results. However, lack of critical appraisal skills on the part of reviewers and guideline creators routinely leads to flawed systematic reviews and guidelines, leaving clinicians with few resources from sorting fact from fiction. The teaching appraisal skills in medical and other schools and other training programs, such as residencies, appears at first glance to be fertile ground for providing clinicians with the needed skills. Surely if you're going to university for, many years, that you're going to be taught evidence-based medicine. Well, it seems that studies assessing medical students' competencies suggest that they frequently do not see or are not taught the relevance of evidence-based medicine to clinical care and are neither motivated nor prepared to apply evidence-based medicine skills. The lack of motivation, that's a difficult thing to read. Upon entry to residency programs, their ability to appraise the medical literature critically is extremely limited. Currently, strong evidence regarding the most effective training approach to equip healthcare professionals with the required knowledge and skills to consistently apply valid research evidence in their daily work is lacking. So what we have is an era of what's known as evidence-based medicine, again founded by Dr. David Sackett, the Canadian physician. It seems that we don't even know how to teach evidence-based medicine to people. So how we can live in an era of evidence-based medicine, those two things don't quite add up. Let's move forward. Problem number 4. Patients and families frequently lack relevant, accurate medical evidence and skilled guidance at the time of medical decision-making. People are bombarded with medical news stories, television and radio talk shows, social media, pop culture magazines, spurious websites, advertisements and hospital marketing messages and other media sources, much of which are incomplete or wildly inaccurate. And again, we've seen that in spades the last few years of the propaganda that was coming out of the mainstream media regarding the effectiveness of these different drugs, and pretty much everything that they claim the last few years has now done a complete 180. Terribly sad. It continues, but many healthcare and medical journalists appear to remain largely unaware of the degree to which the information they gather for stories has been shaped by the interests of the manufacturers and research universities. Mass media consumers have few means of determining the accuracy of any given news item and thus often view evidence through the lens of the mass media. And one of the huge issues of that is not only is the information false, and not only do people not have the skills to determine whether it's true or false, the media often just bombards people with article after article after article 24/7 off the same claims, and so people are more likely to then view them as true the more often that they see them, which again is a huge issue. It's important to remember that patients eventually are at the core of making medical decisions, so ultimately it does fall on the individual's shoulders. The legal doctrine of informed consent requires that patients understand that they have treatment choices and the potential benefits and harms of each choice, while medical ethics recognizes that their values and preferences must be honoured. Shared decision-making involves clinicians sharing medical evidence with patients, eliciting their values and preferences, and deciding with the patient the best course of treatment. So the paper does go on to speak about shared decision-making and the use of support materials for that. That really does seem to help people make better decisions regarding their medical choices. And so the use of decision support materials is something that should be supported more. That's one of the solutions that this paper mentions. And there has been studies done on the effectiveness of using these shared decision-making tools. However, some of the basic barriers to implementing them include pervasive professional indifference, which is very sad, organizational inertia, lack of physician comfort with decision aids, time constraints, which is the big issue, and competing priorities, a lack of training, lack of reimbursement, and perceived work burden and cost. Furthermore, it actually goes on to speak about a study of outpatient visits in primary care clinics, which assess different elements of informed decision making. Unfortunately, it seems that no discussions fulfilled all the criteria for that. Physicians frequently described the nature of decisions, which is good, but infrequently elicited the patient's preferences, discussed alternatives, and less than 10% discussed the risks and benefits. Furthermore, only 5% discussed uncertainties, and rarely, only 2%, assessed the patient's understanding of the decision. In a similar study, only rarely 1 to about 16% did physicians relate to patients the uncertainty of evidence surrounding the recommended treatments. A big issue of that is that the physicians themselves don't actually understand the uncertainty of the evidence. So how can they be then expected to relate that on to the patients? The combination of unreliable medical evidence, the tsunami of misleading reports in the media, inaccurate decisions, inadequate discussions between clinicians and patients, and a culture of patients trusting providers' recommendations and expectations of something to be done together produce massive medical misinformation with suboptimal, non-patient-centered decision making. And again, I think that's probably one of the most important paragraphs in this paper, and hopefully we can spread more awareness of that. Moving forward, the paper goes on to discuss how, there was a study done that claims a 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure, which is, it's quite the statement. Such illiteracy is common, and clinicians thus foster unrealistic expectations about medicine. A systematic review of 48 studies on clinician expectations on the benefits and or harms of treatments, tests or screening tests, show that in most studies, most physicians had inaccurate expectations. Moreover, it was far more common for clinicians to overestimate than underestimate the benefits, and unfortunately, to underestimate rather than overestimate the harms. Their inability to assess evidence further contributes to skewed views among the patients, the media, policymakers, and others. The problem of having so much unreliable and non-useful published medical research may be attacked at its root, but that is by funding, conducting, publishing, and disseminating more true and useful research. However, it's important in the meantime that we make healthcare professionals and basically everybody involved more aware of this trouble, and then provide them with better clinical appraisal skills. Lastly, this paper continues to speak about things such as, even if we can come up with solutions, it's important to remember that any of the evidence-based medicine critical appraisal tools can be subverted. For example, industry-sponsored trials may be performed and presented in a way that they tick all the right boxes and on risk of bias tools, even as some fundamental aspects of their design may still be highly misleading. So although that we can come up with better tools, we always have to remain on guard against those tools then themselves being subverted also. There is no standard package or automated training tool that can be used as a substitute for thinking, and there is no, substitution for healthy skepticism. And so that's important always to have. We need to keep these things like guidelines and, what's published in these journals under a healthy lens of skepticism. In addition, it does mention journalists as well, which need to be trained better because they have to be held a bit responsible for what's gone on in the last few years and for the harm that they're doing by spreading false information. The paper finishes up by stating, eventually, successful initiatives should be part of everyday clinical experience, not seen as an artificial, formal, imposed requirement. Teachers and trainers need ever sharper skills in critical appraisal of the medical literature. And furthermore, all healthcare professionals can take up the responsibility to master skills and become teachers and trainers for themselves and for others during encounters with patients and decision making. That's all I'll leave you with today. Thank you again for stopping by. I'll see you next time.